we need to kind of get that fundamental knowledge right now. So duration, we're looking at how long that client is having to endure the contraction pain. So when we time that, we're going to time it from the beginning of that contraction to the very end of the contraction. And those are usually in seconds, and we want that to be around a minute. And then frequency is how frequent those contractions are happening. So think of the frequency as like when you ask your client, how often are you having a contraction? How far apart are your contractions? So we want those to be about 2 to 3 minutes for active labor. We always want about a minute in between contractions. Why would we want that amount of time? What do we think is going to happen in between those contractions? Resting for the mom or the client, and resting also for that baby. Because we need that blood to be pushed back through that placenta. And we're perfusion, and we're all about it. Okay? So, duration is how long the client's enduring a contraction. Frequency is how often they're happening. Intensity goes for what? What's the word? Yeah. How strong it is, how intense it is. Right? So if we had somebody who's early in preterm labor, they come in and we palpate those contractions, and they're firm to palpation, we need to be doing something, versus somebody who you go to palpate those contractions and it's still really soft. Okay? If there's differences between like a nose, your chin, and your forehead. So you can feel the difference, like your nose is kind of squishy. Well, my nose is kind of squishy. And then my chin isn't as squishy, and my forehead goes with the rest of my noggin. It's just hard old noggin. Okay? So, mild, moderate, firm. Okay?
We're going to go that in.
Yes, you do. Yes, you will. Because we still do it all the time. So, then there's patterns within the fetal heart rate that we're going to be looking for. Okay? So, on one part of whatever you're taking a note on, write VEAL, V-E-A-L. And then on the opposite side, you're going to write CHOP, C-H-O-P. Okay? So let me know when you guys have that written down. So, and do it down, V-E-A-L. And then corresponding on the other side, C-H-O-P. Okay? Are we there?
Yes, sir.
All right. So, in the fetal heart rate pattern, just like with an adult, we're going to be looking for normal sinus rhythm in your adult client, right? We don't want VTAC, we don't want any SVT, we don't want any of that, okay? With our baby, what we're looking for are any kind of accelerations or decelerations. Accelerations are, which way do you think the heart rate's going to go? Up. Just like if you accelerate a car, okay? And these are just the down and dirty. There's lots more details, but just down and dirty for these things. So we're looking for acceleration versus a deceleration. Which way is that heart rate going? Down. Okay. So we're going to be looking at that V first. V of the field chop goes to variable. Okay. So with a variable deceleration, that baby's heart rate is going to be, 140s, 135, whatever is kicking along in the appropriate range. And then it goes down really sharp. And then it comes right back up. It goes down. It looks basically like a V. What's happening with that, on the other side of your V should be the C, and that is for cord compression. All right? So you have a baby, and of course I brought toys today. So you have a baby inside your client. This is hooked up to the baby. This is hooked up to the placenta, right? And baby might have just rolled over and crimped that cord. What do you think is going to happen when that cord gets crimped? Yeah. I don't know how many of y'all did this with like garden hoses and stuff, but don't want to sit there and mess with cranking it down to stop it or going back to the faucet. So you just take the hose and you crimp it off to stop that water coming out. Well, that's basically what happened with the umbilical cord. So no blood is going to the baby. So that heart rate is going to go, and then that baby's going to be like, whoa, and then it's going to loosen up. The cord's going to be all loosey-goosey again. Blood's going to flow to it, and that heart rate's going to come right back up. So what do we think we can do with mom or that client to help uncrimp a cord? Change position. Yeah, good job. All right, so then there's V was for variable, and that's caused by cord compression. And then we have an E, and that goes for an early deceleration. Early decelerations happen with the contraction. It's going to be like a mirror of a contraction. So your contraction is going to go up, and that baby's heart rate is going to come down at the very peak of that contraction. The top of the mountain is going to go that cord. It's going to be the lowest part of the heart rate. And then as that contraction goes away, that heart rate is going to start to come back up. It's going to look just like the mirror image of the contraction. Okay. So, it's for head compression. There's heaven forbid. I need a pen. I came to class unprepared. You need it. Okay. All right. There we go. Okay. Okay. Big gray button. All right. So we have B, E, A, L, C, H, O, T. Okay. So this was a variable.
I'm gonna call her on a break though.
Deceleration, and that equals the cord compression. Okay. So this is going to be, so your variable, your heart rate, is going to be kicking along just fine, and then all of a sudden it's going to go, boom, boom. So it looks like a variable. Okay. So then E was for early deceleration, and that comes to a head compression. Okay, so we have, I'm going to just use Fifi. We have a little bitty Fifi here. She's just a little bit. Preterm babies aren't born with diapers, but I did steal her out of the peeper. So her head, as she's coming down, is getting a lot of intense pressure. Okay, so if you turn to the person that is sitting next to you and you just started squeezing the snot out of their head, what do you think is going to happen to their? Don't do it. Only in your head, right? What do you think is going to happen to their heart rate? It's going to go down, right? Enough time for y'all to escape from squeezing your friend's head, right? So the pressure of the contraction is squeezing the baby's head, pushing that pressure against the cervix, causing that heart rate to go down. So with, so early, so we need the contractions to show for an early. So here's the heart rate, and then as that contraction starts, you're going to see that heart rate go down, And then right at the peak of the contraction is gonna be the lowest, and then it's gonna come back up. All right? So you see how it's like a mirror image. All right? For these, it's very common in our preterm clients. So that's why we need to talk about it, because we're gonna talk about premature rupture membranes, we're gonna talk about preterm labor. So if our client is having early, but we know they're only 24, 30 weeks, 32 weeks, we're like, yeah, pretty much. Mhm.
So the difference is that the variable ones is just kind of random, and then the early ones are during the contraction?
Right, variable unto its name can happen at any time. It can happen with a contraction, without a contraction, before, after, because it goes off of cord compression. The early goes off of contraction. You have to have a contraction for an early deceleration. Alright, and then we have, so basically, nursing management for an early deceleration, they're considered benign, we're just gonna watch it. Okay? And then our A is an acceleration. So these are the positive things that we're looking for. Most L&D nurses, when they get report, we're gonna be, when was the last time our client had an acceleration? Because that's gonna let us know that baby's neurologically doing good, getting perfused, getting enough oxygen, we're doing good, okay? So early, or accelerations are okay. And with acceleration, that baby's heart rate is just gonna be kicking it along, and then we're just gonna have a little bump here, and it's gonna bump here. So, acceleration, it goes faster, right? So you're driving down 40, you get notification that the policeman's there, so you have to slow down, go right back to the speed limit. Policeman didn't catch you, so now you can accelerate back up, right? Okay? And now,
What is it?
you're late. The L is for late.
Okay.
And late is for placental perfusion. So something's happening with our placenta. So our placenta's not doing its job, basically. Okay, so late, it's decreased placental perfusion. So with those, okay, so late. Now with the earlies, we know we have to have a contraction. With the lates, we know we need a contraction pattern. Okay, so we're gonna have our contraction pattern here. So with the earlies, they happened right with the contraction. And we're just gonna watch them. With the late, that baby's heart rate's gonna be like this. And then with the peak of the contraction, it's gonna start to go down. Okay, and we hope it comes back up. So see the difference between an early versus a late? Now, with a late, we're gonna do something because that's a lack of perfusion. So baby's not getting blood and oxygen. So what do you think we could do if we notice late deceleration? Change position, always, yes. If something's happening, we're gonna change position. We're gonna try to increase perfusion. Maybe we had our client tilted over to the left or to the right, and they slid off the little wedge pillow, now they're flat on their back. Well, we don't ever want our pregnant women flat on their back, right? So we're gonna change position. What happens if they just got an epidural and their blood pressure tanked? We're gonna change position, and then how are we gonna increase blood pressure? We're gonna hydrate. Yes, we're gonna increase fluids. All right, just like a normal, not normal, but your typical adult that has like a syncope episode, they got maybe some pain medicine, their blood pressure went down, but you know, they still felt like they needed to get up and go to the restroom, so they stood up and blood pressure, all the blood went to their feet, not truly, but that's what they felt. You know, we got them back in bed, change the position, back in bed, that had an IV, we're gonna hydrate them. So since this is a baby and mom, we also, do you have a question?
Did you intend to draw like the late depression, the contraction, or the late deceleration contraction so big? Is that like to scale, or are they like, is the mom contracting too hard? Would you do?
Good question. I got more paper. All right, so. Like, whoa, there we go. Okay, so they can be big, very long, and basically we're just working on when the deceleration starts. Okay, so it doesn't have to be a huge contraction. It can be just a little contraction. You know, we talked about placental abruptions. That uterus is in a tetanic state. So for an abruption, if we put that monitor on them, they're gonna be like this. Okay? Because it's constant. With that, as soon as it starts to come up, we're gonna see that baby's heart rate go like that. Did I answer, even come close to answering your question? It doesn't look like it.
Honestly, yeah, if the contractions are really hard and we're worried about baby, like, could you slow down or decrease contractions?
Yes, and with what kind of medication?
Oxytocin. No, that's the opposite.
Right, good job, good catch. Okay, I don't think you all have had it just yet, so I was just kind of seeing where your medication knowledge was, so, and that is absolutely fine. It's terbutaline, okay? Old nurses call it breathing, but it's terbutaline. And if we had a client that came in natural labor, just pounding out the contractions, we aren't getting that minute in between, we could give them a little bit of sub-Q breathing to relax the uterus. Okay?
And that would help the late decelerations.
Yeah, yeah.
If they're getting oxytocin.
Yeah. So, but that's just one way of remembering it. Okay, so, yeah. Mhm. On page 327, there's the fetal monitoring strips in the NCLEX Purple Saunders book. So if you guys have that. I think there's some in our textbook. And remember, Mrs. Gottney's going to drive this home next week. But I need you guys to have a concept of those heart rate strips. All right. That is the down and dirty. Awesome. So, always.
So the late deceleration is basically, it's all about the placenta.
Yes. The L goes with the P. So late deceleration is placental perfusion. And think about it. You have that big contraction with that placenta, and that placenta is being squished all that blood out to the baby, so baby's doing fine up to the P. And then as the pressure and the intensity of the contraction goes away, there's not enough force to refill that placenta, so the baby's not getting anything, and baby's like, oh, this isn't good, feel a little weak, as the heart rate goes down. And then hopefully as that true pressure releases, then that blood can come back to that placenta, refill that, and start pushing it to the baby again. So, go ahead. Yes. Mm-hmm. Yes. Just anytime your baby, you're like looking at the baby and you're like, yeah, I'm not feeling this strip right now. Change position. Remember, with everything, we want to do least invasive to most invasive. So the least invasive thing is going to be change position. Yep. Most invasive is when we're hydrating, putting something in our client, stopping something. Yes,
But we've learned that hypertension is a risk for placental abruption, right?
yes.
And so if a mom has really high blood pressure and she's pushing and contracting, would that happen during labor? I presume it does.
So,
And that was, as that's pushing that placenta away and it's not perfusion right, and that's like,
yes,
so fix that.
always. Lates, we're always going to do something about. Early are considered benign. It's letting us know something's happening, but the baby's okay at this point until it wears out. So we're just gonna watch.
Like, did it change from early to late or something? Or like, is it always that?
Always, you said the A word.
Yeah, I know.
Decelerations can turn into other types of decelerations, which makes the whole picture quite muddy, so I'm not gonna tiptoe into that. For the level that you guys are introducing the information, this is the first time you're hearing about it. Remember, veal chop, okay? And then the nursing actions to fix whichever one. So, oh, here, thank you. All right, so all of that is gonna play into the information of dystocias, preterm, postterm, inductions, some emergencies, forceps, vacuum, births, cesareans, and VBACs. All right. You ready? You want the light off?
There you go.
There we go. I'm trying to turn that one off too. Okay, so dystocia. What are we referring to? Could be shoulder. Right there. Okay, so something that's causing our client not to progress at our typical rate of labor, okay? So typically we want to see our client progress about 1 centimeter an hour. Now that's the average because we know at the beginning of labor it's gonna go slower and at the end of the labor process it's gonna go faster. So think of that as the average, 1 centimeter an hour. But there's things that can be going on with our client that's gonna slow it down. The dystocia, putting the whole yield stop sign for the labor, okay? So a dysfunctional labor pattern. Somebody might just be having a contraction every once in a while, or they could be popping out a whole bunch of contractions back to back to back to back to back to back to back. And one would think that, wait a minute, those are gonna make them go faster, but sometimes it doesn't. All right? So, the build of our client, somebody who is less than 5 foot often has a problem, difficulty progressing at your typical rate. Does not mean that they cannot, it just means that that's a risk factor for dystocia. Yes?
I was gonna say, I had dystocia and and they said it's just my hips. So the hips were too small.
You didn't have those birthing hips?
No, not hips. Now I do.
There you go. For the rest of your life. Huh. So, there's different openings, and then some hips are smaller, not as wide as mine. So, I mean, you can see just the little bit of a difference versus the opening, how just like, a half an inch can make a huge impact. So yes, 100%. My grandmother was full attacked, and she goes, "You got those birthing hips, don't you?" Yes, guess where I got them from? Granny. So, I'm from the north, that's how we show love. Just so y'all know how we show love. Alright, so, male presentation, or that baby's not settled into the pelvis in the best way. So we have our pelvis. I've got my baby. And a umbilical cord. There we go. Alright, so we would want our baby to be vertex. Okay? But sometimes that baby's, instead of coming down like this, baby's coming down a little asynclitic, which means that head's tilted a little bit. Or baby decided, I don't want to be head first, and I don't want to be a breech baby, so I'm going to be a transverse baby. Can that come through that pelvis? No. Yeah. Okay. And then if we have a breech baby, you know, feet or bottom first. Yep. So this, the babies can usually come through. We'll do a footling breech. So those can come through, but what's the biggest part of the baby? The head. So you might get this whole baby that slid right out, but that head's not going to slide out. Now what are we going to do? Here's the, there we go. Okay, so here's our whole baby. This is sticking out. What are we going to do? Some are going to panic. The others in the room might be panicking, but you won't, because you'll be like, I got this. Yeah. We're going to make sure the physician knows right away, hey, I got a whole baby except for the head sticking out. It's stuck up in there, right? So there's a couple things that we can do. You can always put your finger in the baby's mouth, pull it down, try to decrease the circumference. Sometimes that'll work, sometimes it doesn't. If it doesn't, that's a 100% C-section. And we're running to the C-section room. If they don't have an adequate epidural, they're gonna sleep her and deliver the baby. Okay?
If they had to have already had an epidural at that point, could we do like an emergency or are they just doing it?
We'll put her to sleep. Yeah, there's no time to mess with that. Mhm.
So, let's just say the feet already hanging out. We still doing C-section?
If the head can't come out,
So I'm just trying to picture.
yeah. And, okay, well, this is gonna cause you some therapy. So we got the baby out, right? Looking, making sure the doors, nobody's peeking in. That's all I need. Dr. Morris be like, yeah, I'm gonna come to your lecture today. Here's the baby. Okay. So you had the, I'm sure there's other recordings. Here we go. So, something down there. So cephalopelvic disproportion. Just breaking the word down. Cephalo, head, pelvic, pelvis, disproportion. Not proportion. Yeah, exactly. The baby's head is too big to come through mom's pelvis. All right. It's either too big, in the wrong position. So, pelvis. Babies aren't born with diapers, but this one is. Okay, so that baby gonna fit through there. You got those birthing hips. Not built like nice water. So, baby's not gonna fit through there, or baby's coming down. OP, which is sunny side up. We know this is mom's back because here's the, okay, pubic bone is up here. So baby might be coming down, looking up. Our typical best delivery option is if the baby's looking back, or an OA instead of an OP.
Is it more painful
Is it more painful? They say that the client does experience more pain because of the positioning of the baby. Because with it like this, all the feet and everything are pushing towards the back, and you have a nice rounded area here. When it's OP or sunny side up, you can see all of this is here, and then all that pressure of the big backbone and all that is pushing up against mom's backbone, and then the feet and everything are pushing it up front. So yes, they do say that it's malpresentation is just any time that baby's not positioned in your best option to be delivered. They're so sneaky. All right. So then maternal fear and fatigue. Why would that play into anything? They're tired pushing. They might have been in labor for 24 hours, right? And they're like, I'm over this. I'm over this. Just want the baby out. That's a lot of work. Who has, like, moved all their furniture around in their house? Just to move it back to be like exactly where it was when you began. Right? Okay? At the end of that day, you don't have lots of energy left because you just pushed everything around, and then you're like, I was wrong. Bless you. So then you gotta push everything back. You're spent. All your muscles are spent. Same thing with the client. That uterus is this big honking muscle that's causing all the pain. Contracting, releasing, pushing that baby down, right? They might have gotten some pain medicine. Causes lots of fatigue. So they just can't push effectively, they can't deal with it. Where does the fear come in? Just having a baby can cause that fear, right? Maybe they are a single person, no support, or maybe they, there you go, because that does happen, right? First time person having a baby and they're scared to death at having a bowel movement. I don't know, I'm like, just push like you've been constipated for like a month and now finally the laxatives are kicking in. I don't want to poop on you. Won't be the first time. Go for it. I don't want everybody to see it. Nobody's going to see it. Sit there and run. Cover it up, change the chucks, keep going. But, just let them know, if you are pushing the stool out, you are pushing the right way. So you go for it. Push. Bless you. And they can sneeze them out too. Sneeze them out, throw them up, out, all of it. Alright? Where's my color clicker? I love coming to class with babies. There's just something about walking around with a baby. Okay, so. Okay, just going off this one. Alright, so let's see. Dystocia is meaning something's happening. Alright, so here are some of the powers. So there's powers, passenger, passageway, psyche, as far as the powers, the P's. Okay, and these all go with the whole labor process. So this one up here, the A, that's our typical, that's what we want to see. Nice, rhythmic contractions, bless you. The B, those are hypotonic, because we know hypo means not strong enough. These are just creasy bumps. This might be somebody who's going into labor, might be somebody who has a UTI, somebody who has the flu, somebody who just doesn't feel good. Okay, so their uterus is irritable. With an irritable uterus, it's going to kick out a few contractions, but they're not going to be strong enough to actually do anything. And then you have your C, we don't have enough contraction. D, this one is very typical of your CPD pattern. We're kicking out some contractions, but not a whole bunch. They're kind of coupling and tripling where they're feeding off of each other, so that uterus is working really super hard to push a baby through. It's just not gonna work, bless you. All right, and then that very bottom is too much hypertonic contractions. So you can see the difference in what it would be. So if we have one that's not enough contractions, we can give them oxytocin. Because oxytocin is a synthetic hormone that's gonna work on the uterus as far as contractibility, causing those contractions to increase in frequency and duration.
What would be, like, that?
Hypo, yeah, they're just kind of irritable. So as far as E, we kind of hit this one just a little bit ago. E, we want to slow down those contractions, so we're going to give them tributaline, a tocolytic. So toco contractions, lytic means cut. So we're going to cut the contractions, give them a tocolytic. Tributaline is our usual go-to. There's a few more that are
Just see more
in the slides somewhere, but
Okay.
Are the students like Braxton?
they could be very early labor in the latent phase. They could be Braxton Hicks. It's just not enough to where we want them to be. Yeah. So here's like true signs. Okay, hypertonic versus hypotonic. Trying to look around my cup. Bless you. All right. So we're not gonna worry about the baby's heart rate here, but hypertonic. See how it's like bum 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 bum, one after the other. Versus hypotonic, not enough. Client just can't get comfortable, no. Then they have a contraction. Okay, and then they're just rolling around in bed.
What's the time for,
Each one of these, the darker lines, this one it's hard to tell, like here to here, but on here it's a little bit easier. The darker lines that go up and down, those are a minute apart. So each one of the lighter lines are 10 seconds. So with here, how I would document it is client had a contraction in 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 in 12 minutes. Because I can't tell you frequency. Can't tell you how often they're happening because I only have one. Okay? All right, so passenger, we talked about some passenger problems with male presentation, breech baby, could be twins, cervix just not opening because the baby's not engaged, so it's just floating around, it's blottable. So I even brought a cervix today. Because I got the thing, right? And it's Friday. And we need things on Friday. So cervix, actually be like this. Okay, so this one is about 3 centimeters. So then if that baby's not pushing down on the cervix, it's blottable. Is it gonna open? No, likelihood is no. But if we get some pressure, don't ever hold your babies like this. Get some pressure on that baby. It should, and I didn't bring mineral oil. But that baby can start to stretch that cervix, thin it out, and push it open. Yeah, okay. Alright. It would go easier if I brought the mineral oil. But that's when you guys touch them and you feel them like they're slimy, that's what all that is. But yeah, so if that baby's not pushing down on that cervix, it's not gonna do it. Alright, so we'll just run through a few of these and then let y'all take a break. So macrosomia,
Big fat baby.
big fat babies. What kind of client would these babies usually come from? Wow. You know Mrs. Tidwell just smiled, right? Yes. All right. An OP baby. Baby's looking up, right? Sunny side up. Or a brow presentation, and that's exactly what it looks like as the baby comes out. So the cervix is here. So you can see where that would cause a lot more problems, because this is an easier. Okay, this will cause a lot of neurological problems, and usually that's what we're gonna look for, okay? And then your breech babies. But you can see where that's not gonna be as easy to be delivered. All right. Shoulder. Let's take a break before we do shoulder doses and all that. Here's for mom's pelvis. So their head's coming out, and the way that it typically, what the nurse and the physicians are gonna notice is called a turtle sign. Okay, so you know the turtles, they're walking across the street and they see you coming, and they're like, whoop, right? They don't, their little heads aren't all sticking out anymore, they're all tucked back in. Turtle sign is exactly what happens. So mom's pushing, baby's head's coming out, but the shoulder's stuck here, so baby's pushing. As soon as that contraction relaxes, it comes back. Okay? So it comes out, and it comes back. So the turtle sign. So what are we gonna do? We're gonna help deliver this baby, right? Bless you. So, we're never gonna do that to our babies, but I just did that. All right? So basically, if we recognize the turtle sign and we're in there to help the physicians, we're gonna call for additional help, because we're gonna need to get those legs back to open up the pelvis. So we have mom's pelvis just like this. So here's the pelvis, okay? If we take mom's legs and move them back, because I'm as graceful as a ball, right? So we're gonna take mom's legs and pull them way back, okay? So we're gonna, instead of them coming up like this, we need them to be out like a frog and way back. And what that's gonna do, stretch out my hips a little bit. Taking them way back, instead of the pelvis being like this, it's gonna open it up ever so slightly. So here's typical, move those legs back. A lot of times we just need that extra space, a couple millimeters, slide that shoulder under. If that doesn't do it, yes?
That actually happened with my son, and he was, like, he was a giant baby, he was a 10-pound baby, and he broke his collarbone.
Did they break it, or?
No, I guess they didn't know that it was broke. It was like probably 4 weeks later, and he ended up getting like a calcium deposit right there, and it was like a huge knot, and that's what they said, is that he had broken it, I guess, during birth.
Okay, yeah. So,
And he had no problems, like, he was like moving his arms up and down, like it didn't bother him at all.
that's good, because usually they won't
Uh-huh.
move that one
He was
arm.
doing it.
Yeah, well, good. Not good that he was 10 pounds, but yay for you for delivering a 10-pound baby. Those are the birth and halves. Which are good. We like those here, okay? So we want those legs way back. If that doesn't do it, and mom's pushing, should we push on the top part of the uterus? Do we think that would help? That's about a 50-50, right? So let's see. We have the baby. Baby's giving us the turtle sign because of the shoulder. So the shoulder's right here. If we do extra pressure back here, is that going to help? No, it's not. It's actually going to impact that shoulder even more. And that's called fundal pressure. Don't ever do it. I can't support, I'm a legal consultant with the L&D stuff. I can't support the nurse's perspective when they write fundal pressure applied. I'm like, wow, man, don't ever do that. Yes,
Are
sir.
you able to like reposition the baby?
You can reposition the baby. Before we do something to that extent of being invasive, we're gonna just try to push that shoulder underneath, okay? So it's called suprapubic pressure, and as the nurse, they're gonna take their fist, put it right on the pubic bone, and we're gonna roll it.
We do that?
We can do that, yeah.
Is it painful for the mom? Is it hurt the mom when you do it?
Mom's pushing, so if mom has an epidural, they'll probably feel the pressure. At that point, it's really an emergent kind of a situation, so we're telling mom what we're doing, you're gonna feel lots of pressure, I'm gonna be trying to push your baby's shoulder underneath your pubic bone when you're pushing, okay? So ready, and pull those legs back, deep breath in, bear down as hard as you can. I'm up on top, off to the side, I'm never gonna be on top of my client, because that's wrong, all right? And I'm gonna take my hand and roll it to pop that pubic bone. Shoulder underneath the pubic bone to push that out, okay? So we have legs back, suprapubic pressure, right? And then also the physician is helping to guide the baby. I'm running out of hands. Oh, don't ever do that to your baby. This is like so we have baby, and so the physician is gonna pull down, out, and up. Okay? So if all of this isn't working, we're gonna have to, we, physician, whoever, try to go up inside mom and manually relieve that shoulder. And you do that by, you're gonna deliver the bottom arm first. Okay? Because when that bottom arm is delivered, then all of a sudden it shifts those shoulders, and then you can take the other hand and bring it down and up. Is this uncomfortable? Yes, it is, but we're saving lives.
So I imagine doing all that related stuff with domestic maybe like vitals.
Yes.
Like, how long are we gonna be trying to get the shoulder out if we can't get it out before we're like, okay, we're going? Because how long can they be okay being compromised like that?
Remember, they still have the umbilical cord, so they're still being perfused. However, that big thoracic squeeze is happening
Yeah.
because baby's coming down, so we got that huge squeeze here, so we're gonna be doing all this within a couple of minutes. Yeah.
If it doesn't work, it's like, well.
Sectional. Yep, but I mean, you can break a collarbone, you can pop a coccyx, tailbone. It just really depends on size of baby, size of mom's pelvis. Because 10-pound babies, those are about 3 pounds over average.
It
typical.
fractured my tailbone too.
Yeah. Trying to make as much room as possible, yeah. Bless you. Yeah.
Wouldn't you break asepsis if you like stick the hand in there?
You got cerebral.
When wouldn't it be
See where you're going. A vaginal delivery is truly not considered a sterile procedure. It is considered a clean procedure.
Oh.
And at that point, we're saving a life. We can always give antibiotics.
Alright.
Yes. But that's a good question. All right, so shoulder dystocia, remember helper. We're trying to get everything moved as fast as possible. All right, so passageway refers to the pelvic and pelvis in the vaginal vault. So the gynecoid is what we consider your best delivering pelvis. Just remember, most women go to the gynecologist, so the gynecoid shaped pelvis. The other shape doesn't mean that you can't have a baby, it's just not the preferred shape. It doesn't give a lot of room. You can see, this is round, this different shape. Okay? Soft tissue, we talked about your previa, and why can't a baby be delivered through a placenta?
I did it for you.
Right. Exit. Oh, can't go through it. So if your client has placenta previa, no. A fibroid in the lower part of the uterus. A fibroid is like a benign tumor in the uterus, the lower section. So that baby can't go around it. Yeah.
Okay, so one of my patients that I had in postpartum, she had a fibroid, so she had to have a C-section. Why did they not remove it?
Bleeding.
Okay.
And they're benign. A lot of times they're fed by hormones, so we're going to try and see if that's going to decrease the size of the fibroid. But yeah, and then if they take it out right there at the C-section, huge amount of bleeding. And then if there's too many, they would end up doing a hyst, and then that's a lifelong decision here. All right, a full bladder, full rectum. Why is that going to cause a problem? Yeah, there's no room. So as a nurse, what could you do?
Have them void for
Put a catheter in, have them void? What if it's a full rectum?
Oh, they're gonna push it the right way, so it's coming out.
There you go. Hopefully they'll be pushing the right way, it'll come out. If it's not, just help it.
Oh, no.
Because it's right on the inside, you can feel it, you just help it out. Say, I can deal a lot better with this end than somebody throwing up on me. I'm like, ooh. That's just, okay? Kind of explains a lot of the different attitude I got, right? Personality. Crazy. All right, so then psyche, we did the fear and the pain, and if our clients aren't able to feel comfortable, feel that support, they're in too much pain. Think of when you're in a lot of pain, what's your body gonna do? Tense up, everything is tensing up. And if we want that baby to naturally and easily slip through the pelvis, we need it to be in a relaxed state and not everything all squished up. Okay? So if they're in a lot of pain, we're going to help to relieve it. Support as that nurse, that caregiver, you're there for that support. Okay? So you'll be the support that they don't have, or you will be the gatekeeper if they have too much support. Okay? All right, preterm. Preterm, we know preterm refers to anything less than 38 weeks, so 37 and 6 days. Why would somebody deliver early? Could be an abruption. Your membrane's ruptured.
Placenta's not providing enough nutrition to the baby.
Right, we're getting some IUGR, intrauterine growth restriction. Baby's not meeting the markers.
OB's going on vacation.
Baby's going on vacation. Now we're just gonna slide in there. But that's real life there. Twins. Preeclampsia, yes. Twins, yes. Hypertension, yes. Anything that's putting too much stress on the baby, baby's better out than in, we're gonna deliver that client early. They could just be going into preterm labor. Also, dehydration. Oh my goodness. Here in Arkansas, it gets up to like, what, 150 degrees in the summer, right? Crazy. Y'all survive, y'all are survivors here. I'm not as strong. So you can dehydrate super quick being out that in that crazy heat and humidity. Bless you. So our clients, you know, they don't want to go to the bathroom a whole bunch because, you know, that happens all the time. So they aren't drinking enough fluids. They aren't drinking the right fluids. It's easy. They aren't drinking the right fluids, right? Make eye contact with me. I'll put down. So, that's going to predispose them to preterm labor. All right? So, where's my thing? All right. So with our membranes, we're just going to talk about preterm rupture of membranes. And this is fallen back into the last lecture that I did that we didn't get to the amniotic fluids and all that. So premature rupture of membranes is any time that membrane breaks before that term period, okay? And then we have another deviation of prolonged preterm rupture of membranes. But if you just remember the umbrella term of premature rupture of membranes, that'll get us far. All right. Now, our client isn't in labor. They aren't contracting. Their cervix, these thingies, okay? So, our client's cervix is basically uneffaced. I would say this was about 50% effaced, but bless you. And just the fingertip, they're like at 35 weeks, but their water breaks. What are we gonna do for them?
Deliver the baby.
They're 35 weeks. All right, so I've heard lots of great things. Oxytocin, which would induce contractions. I've heard deliver the baby at 35 weeks. Heard put on bed rest and then stop labor and monitor. Who thinks we should deliver a 35-weeker?
If the membrane rupture, yeah. I mean,
All right, so kind of an up and down. We can see some pros and some cons to it. Yes,
It also depends on baby's lung development, right?
maturity, yep. So just because our client's membranes ruptured at 35 weeks or preterm doesn't mean that we have to deliver our baby. Cervix is basically fingertip, non-effaced or thinned out. Okay? So we got lots to hold the baby up in there. Mom's not running a temperature. Heart rate is doing good, showing us accelerations, which those are positive signs, not showing us any decelerations. So we're going to monitor bed rest, maybe put the client on some prophylactic antibiotics. Yes, sir.
so also when the membrane structure is not the same as like amniotic fluid, like we can.
It is the same. It's exactly the same. So if that's happening in a preterm state,
Would that they refill?
you know, well, it's not gonna refill per se. That amniotic layer, that amnion, is always going to be secreting some fluids, and then the other part of the amniotic fluid is the baby's urine. So it will replenish some, but if it's a gross rupture, which I mean, it's not just leaking like you have a soft spot in a water balloon, but the water balloon actually went
Yeah.
and all
That-
over.
That's what I was thinking when you said rupture. So.
Uh-huh. And both of those we're really gonna treat the same, preterm wise. As long as baby's doing good, mom's not showing any signs of infection, we're going to monitor mom and baby.
How long can you go after if they rupture fluid, like how long can they be on bed rest?
We're gonna watch them.
Just
Just watch them, because if I have a client who's 27 weeks with gross rupture membranes, I know if I deliver that baby, the lungs are not gonna be mature. So what can I give the mom to mature baby's lungs? Steroids, right? The betamethasone. We're gonna give that to mom because we can't give it to the baby, right? Because baby's still inside. Remember, this is preterm. Mom's not showing any signs of distress, baby's not showing any signs of distress. So we're gonna give mom some steroids to increase baby's lung maturity. Hopefully hold off for a week. And then if things start to go south, meaning chorioamnitis is starting to develop, infection of the amniotic fluid is starting to develop, heart rate is not giving us our positive signs, mom's white blood cell count is starting to go up, she's starting to get a very tender uterus. These are all signs and symptoms of chorioamnitis, infection of the amniotic fluid. At that point, yeah. We're gonna be watching them. So if they give us signs, so if we have oligohydramnios, which would be a smaller level, remember oli is small, poly is large, okay? Oligohydramnios, we have that amniotic cord in there. What kind of heart rate patterns do you think we're gonna see? Variable, starts with a V, variable, because it's cord compression. So we're gonna be monitoring baby, we're gonna be monitoring mom. But if both are doing fine, we're gonna try and keep baby in there as long as possible.
Is all this monitoring done in the hospital, or is it at home, or?
Yes,
Both?
yes.
Okay.
And it truly does depend on how mom's doing and how baby's doing. If we had leaking of membranes and we're doing a biophysical profile, we're seeing that mom has good patches of fluid after they prove themselves that they can be stable in the hospital, then we can send them home on bed rest. If it's a gross rupture, super duper early, and we do a BPP and biophysical profile, and we don't see a whole lot of amniotic fluid, 9 times out of 10, they're not gonna last a whole long time. So those are the clients that we're gonna see in the hospital for longer periods of time. Can your membranes rupture without?
But I didn't have any fluid, and I guess I didn't have
They could have been leaking slowly, that you were just thinking it was extra discharge, water discharge, because we know with the increase of hormones, we get a lot more discharge. Could be the baby acted as a plug, that big gush wasn't gonna happen until after delivery. So there's a couple of different reasons. So as far as 2 centimeters, you were this far dilated.
Yes.
Yeah. So that's 2 centimeters. All the way up to your 10 centimeters. Okay, this is when the baby's coming out. The face, 100% of face, I would call this 90, but then 10 centimeters. Okay, so premature rupture membrane infections, right? Chorioamnitis, we're gonna be watching for those signs, watching to see if we can control labor to get those steroids in that was important for you. Wednesday. All right? These are all those signs, maternal fever. Baby's heart rate's gonna go up because mom's heart rate's going up. There's an infection. The uterus is gonna be tender. Why is the uterus tender?
Infection.
Because there's an infection going on, right? Yes.
Could you turn your mic on so we can hear you back here?
You know what? I bet you my battery went down. So kind of, but wait a minute. I do have one. Good. Infection of the amniotic fluid. So urine tenderness, that fluid is gonna smell bad. Amniotic fluid will usually smell a little bit like urine. If there's meconium, if that baby ended up having a bowel movement inside that amniotic fluid, most likely will not have a different smell because meconium is really considered sterile until it hits the air, but it's gonna be green, kind of like the backpack, right back there, that green. Yep. And it can be chunky, or it can just be fluidy. We would call that particulate meconium, or just regular meconium. Now, meconium is the baby's first stool. It's like the miraculous stuff that's forever being wiped off, right? It's like what Vaseline meets tar meets something else that you just kind of keep wiping. So if baby, yes,
We had a baby that we went into discharge because they were constipated, and so we did a rectal stimulation on them, and a big mucus plug like this big came out.
yeah. But I bet it didn't smell. No, that's the best part of meconium. There is no smell. Yeah, until they actually go home and then all that transition stool. Yeah.
Sorry. That's like when the baby has very bowel movements. In the Philippines, they think that's like the worst thing that can happen.
Inside?
Yes.
That is not a positive thing we ever want to see. Yes. So, yes, I can embrace that thought. That it's not it's like one of the worst things that can happen.
Yeah.
What it's
Like if the baby does a bowel movement while inside.
Yes.
So when I was on my labor and delivery unit part, so we pushed for like an hour and a half, almost 2 hours, and her liquid, or her fluid was clear, and then when we went back in to push again, it was like really thick and green. So I guess it can happen at any stage.
Yeah.
Like after the fluid rupture.
And it can happen at any stage during the whole pregnancy. And we call that an insult, that something happened during that pregnancy, an insult or a traumatic event. And think of the baby had the scared out of it, right? Okay, because it's its bowel movement. Right? So that's what happened inside. So that lets us know at some point perfusion went down, there was some trauma to that pregnancy. But if that baby breathes that in, so think, it's like Vaseline. It's thick. Baby breathes that in. What's it gonna do to the inside of the lungs? It's gonna coat all those alveoli, right? Is the oxygen gonna be able to penetrate that? No. So what's gonna happen to gas exchange? It's not gonna happen. Nothing, because it's not gonna happen. Is that a good thing or bad thing? Bad. Bad. So yes, yes.
It's hard to clear up too. My son was in the NICU for like a month and a half because he had pneumonia aspiration.
Yes, and that's meconium aspiration pneumonia. Because it's sterile while it's inside, but once it hits the oxygen, that bacteria is can drop a Delete on that baby and try and suck it out. If it's in the oral cavity at all, they can drop it in there. So, yeah, we want to suction it out as much as possible. Yeah. The age, how long it's been in there.
So is the meconium, if they have, meconium in their sustained fluid, does that count as the baby's first bowel movement, even though they're not? You know how you have to pass protocol with bleed, does it count as their first bowel movement?
We're gonna document that they did have a large amount of meconium, or it was just light green staining or particulate meconium. If it was particulate, we know that there was a lot that happened. If it's just a real light green, we're gonna expect that baby to have some more. So it really, as long as that's documented that that happened, we won't have that bigger expectation.
I was just gonna say, with the meconium statement, my baby had it, and as soon as she came out, she said it, scared me, I was like, ah, but she did do the section, and then she also applied oxygen, and after that, she was fine, so I guess she didn't, or maybe she got her,
It could be, a lot of times when we do drop the leaves, it'll bagel our babies out. So she might have just been trying to pop that baby back up.
Yeah, okay.
You might not have been seeing it at the other end with that.
And I saw the
Yeah.
oxygen mask, and I was like, oh,
And a lot of times if we know we're gonna be doing some resuscitation, that's why God made me this size. I stand in between the baby and the mom until that baby starts to cry, and I'm like, see what I'm doing? See what I'm doing right here? But, yeah, unless they, wanna see and they're like, can you move over? Of course I can, but, yeah, I was made this size for a reason. Okay, so we know about chorioamnitis, meconium. Oh, I love my little preterm baby. Okay, so preterm, there's some differences in terminology as far as preterm labor and preterm birth. Just because our client's having preterm labor doesn't mean that they're gonna have preterm birth. Because if they have preterm labor, they're just having labor. Please don't take your jest as I'm belittling it because it's a big thing. They are having labor in a preterm time frame. But we can give them medication to stop it, right? So as long as their cervix is, oh my goodness, nice one, come on. Great, there we go. Is fingertip closed, not making active dilation or effacement? Water's not broken? Mom's not having distress, baby's not having distress? We can give the tocolytics. Slow those contractions down. If we get them to completely slow down and stop, mom's doing good, they can go home. They might go home on some tocolytics or breathing. Yes?
So for preterm labor, would you want them on bed rest as well?
Really depends on
Or
what
like go
caused
about
it.
their daily life?
Depends on what caused it. If they went into preterm labor because they have a UTI, we can stop contractions, give antibiotics, treat the UTI, treat that problem that's causing that, as long as the cervix is remaining closed, 1, 2, whatever, not actively dilating. Go on with your bad self, right? But if it's for a different reason, water's broke, they are actively dilating. No, I would say no, because they're now preterm labor, high risk. And then the hormones with the semen on that cervix is gonna cause that labor to come back. I saw somebody's hand. Okay. All right, so then,
Like they got my mom 3 times for labor, and then he ended up delivering.
we stop it until we can't, you know? Yeah, because we can start with something as simple as as simple as a PO tocolytic, like breathing, something like that. And then if that doesn't work, then we can throw some mag at them. And then if that doesn't work,
So like she would go and like she would stop and then they'd be able to send her home and then like she would say, oh, go back to the labor. And then one time they'd move out. So they'd be just-
yeah. And that might be the cervix went from a smaller cervix to actively dilating, you know. And then we got to 5 centimeters. Seven or so to 10, you know. If they're actively dilating, then they're no longer preterm, or no longer something that we're actually gonna be able to stop. Yeah. All right, so preterm birth is when birth actually happens, yes.
So if you send them home on bed rest, do they continue their normal appointments, or will they have to come more often?
They will most likely be coming more often. It'll most likely be weekly at that point. Yes. Good question. So preterm labor, just when it's happening, preterm birth, that baby's actually being born. Okay, and then something that's completely different is a low birth weight baby. Low birth weight baby is a baby that's just underweight. So they could be born at 39, 40 weeks, but mom had this little pipsqueak of a 4-pound baby. That baby's a low birth weight baby. Doesn't mean mom was doing something that they weren't supposed to be doing. It could have been a low-lying placenta, decreased perfusion. Mom could have been a smoker, could have just been, that's what they're genetically are. You know, we know that there's some people that have big babies and there's some people that have small babies. So with a low birth weight baby, we know that they aren't gonna be as stable as far as maintaining their heat, maintaining their temperature, because that fat layer isn't there to insulate them. Okay? So all 3 of these things are different. Such a cute little baby. Alright, so risk factors, we kind of hit them, okay? So what are they doing? You know, how is their body? Are they a healthy person? You know, what's that pregnancy look like? Are they experiencing issues? And then, what are their habits? So preterm, we kind of went through this. So some testing to see if our client is going to go into preterm labor, because it's not always a surprise. We're going to do vaginal exams in the clinic. So if we come in and we check our client and they're basically uneffaced, 25% effaced, and then the next time they come in, their cervix went from this thickness to this thickness. So something is happening in that preterm state. That's going to place them into a high-risk category. Why? What difference does that make? The thickness of the cervix. It's less strong. Think of those real big fat rubber bands. Right? They're harder to pull apart versus the little bitty skinny ones. So that mom, we went to check her, or that client, and we noticed that it's a smaller effacement or thinning out of the cervix. That's letting us know that's our yellow flag. And then we can also do a swab up inside to check for some fetal fibronectin. And what that is, it's the fibers that between the amniotic membrane and the uterus that holds it together. If those are there, that's like an indicator that that client is going to go into preterm labor. Okay. We hit some of these things already as far as nursing care, bed rest, if we can't stop it, or if they're still very irritable. some of the tocolytics, terbutaline, magnesium sulfate. What else do we use mag sulfate for? Seizures, right? To decrease the seizures in our gestational hypertensive and preeclamptic clients. So why would we give it to somebody who's in preterm labor? Are they gonna have a seizure? Let's hope not. What's mag?
To relax the muscles.
It's a smooth muscle relaxant. The uterus is a smooth muscle. So those of you that have gone through L&D, anybody on MAG? No? So why were they on MAG?
To prevent some.
So they were hypertension clients. So we're gonna do the same protocols if we're giving MAG for somebody who's a hypertensive client versus a preterm client. Now, which one of those clients do you think has a bigger chance at developing MAG toxicity? Somebody with gestational hypertension or preeclamptic versus somebody who's in preterm labor? Okay, so who thinks preterm labor would have a bigger chance at becoming toxic with MAG? It's okay. Okay, those that think that client who has the hypertension issues. How about some that just really don't have a clue? All right, it's okay. That's why y'all are sitting here, right? To get the information. Yeah. So our clients that have the hypertension issues, one of the things that we're watching for is their output, right? Because preeclampsia is going to be causing vasoconstriction or vasospasm, affecting the kidneys, which is going to decrease the output. Where is MAG filtered out? In the kidneys. So in a hypertensive patient, that's not happening. So the MAG's going to build up and build up and build up. Now, our preterm client, are they having vasospasms or vasoconstriction?
No.
No. Is anything wrong with their kidneys per se?
No.
In our typical NCLEX world, preterm client, no. So that MAG can be filtered out. All right, so we still have to watch output, we still have to watch levels, all of that, but our MAG, our client that's getting MAG for hypertension is more likely to get toxic versus our preterm labor client who's getting MAG. Now, are they gonna feel the same? That flushing? Yes. Are we gonna decrease stimulus? Yes, because they both have issues that are going on. One's in preterm labor, the other one we're trying to not have a seizure. So if we're giving a client with preterm labor MAG, we know it decreases everything because we're slowing it down. What do we think it's gonna do to the baby's heart rate? We're gonna smooth that heart rate out. We're gonna mellow that baby out, right? So if they end up delivering, what do we think is gonna be depressed in the baby? Respirations. Okay. All right, just a fun note. What is the antidote for MAG?
Calcium.
Okay, all right. Let's see. These are all the types, Procardia, Indocin. These are ones that we can also give for a tocolytic, but really our go-tos are the terbutaline and the MAG. All right, the Indocin and the Procardia, if we give those too early, they can actually cause some cardiac issues in our babies. They can close the ductus, and we don't want to do that to our babies inside because we need them to be going around. So our go-tos are the terbutaline and the MAG. All right, so post-term, this is a good place to stop for our little break, our last drink drink some of the tea we keep saying don't drink, right?
Can we get them to start pumping? Like,
Can they start pumping? Yeah, because that'll release natural oxytocin. And actually, nipple stim is one of the things that they can do also. And that will, it's exactly what it sounds like, it's nipple stimulation. And they'll do that to release oxytocin. So yes. Yeah,
Is it common practice really anymore for women to go this long? I mean, I know it used to be, like, my mom had me at 42 weeks, but that was in 1982. And like, you don't hear about it.
with the amount of lawsuits and the lawsuit happy perspective a lot of people have, most physicians will not go to this extent unless that client says, I wanna do it naturally. And I got a niece, she's on her third baby and all of them were after 42 weeks and I'm like, girl, you're killing me. So, because I'm like thinking everything that can happen and I'm not gonna tell her that because she's pregnant, she's my niece, right? But I'm like, hey, have you tried this? Which is always an awkward conversation to say to your niece. But, yeah. All right, so kick counts. Why are we gonna encourage our client to do a kick count? What's that gonna do? Make sure that baby's doing good. So how many kicks do we want? 10 and 2, right? And what's gonna happen if they don't get 10 and 2? They're gonna go to the hospital. We're gonna do an ultrasound, make sure everything's fine, do BPP, biophysical profile, NST. We'll make sure baby's doing good, and if baby's not doing good, we get to do an induction or an augmentation, right? So what's the difference, would you think, between an induction and an augmentation of labor?
Induction is not induced.
We're gonna, I think you all are there, so I'm just gonna kind of narrow it down a little bit. So, give you an example. You have a person who wants a breast augmentation. Are the breasts already there? Yes. We're just gonna make them, put them back where God intended them to be most of the time, right? So when we augment our client's labor, the contractions are already there. They aren't strong enough to effectively dilate the cervix, but they're there. So we're gonna augment. Now, induction, we're going to induce the labor process. So the contractions, if they're there, they are just like minimal, minimal, if at all. So we usually are like, they aren't contracting at all. So we're gonna induce the contractions. What medications are we gonna use? Oxytocin, yes. All right, so if we have a client who's just a little bit early, say at 38, 39 weeks, they're technically considered term, but we really don't like to do inductions until 39 weeks. These are the reasons that we would do that. Gestational hypertension. Why? Because that placenta, right? We want to make sure baby comes out and does fine. How about diabetes? Right? We don't want that baby to keep growing and growing and growing, because if it gets too big, it's not going to come out. If it gets too big, there's other issues. Okay? Suspected IUG, intrauterine growth restrictions, so maybe mom's been doing everything right, but that baby's just not meeting its markers. You know, she's measuring fundal height about 36 weeks. And it's been that for a couple weeks. Something's going on. Yes, ma'am.
So when a mom is term, does it kind of depend on the doctor when they should schedule an induction? Because, like, I was induced at 40 weeks, but it cut off as like 42 weeks, so I would be sending it at 40.
allowed to schedule an elective induction prior to 39 weeks. There always has to be a medical reason to do it before 39 weeks, but we can do it after 42 weeks.
Didn't they schedule the induction before 42?
Oh, we schedule them as soon as mom looks at us and says, when can I be induced? Because we're gonna get them on the books. And then that's a little bit of a psychological, this is my
I
end
felt very
date.
comfortable sticking my
Yeah.
hands
So,
in
Oh, yeah.
Apple.
yeah. We're like, well, what's our due date now? Scheduling this like 2 months out. Like, yeah.
First.
Like, okay, we're just adding to the book at that point. All right, so an IUFD, intrauterine fetal death, with these clients, 100% up to them unless mom is having an issue health-wise. And then if that is the case, then we will do an induction of labor. But if mom is not having any kind of health problems and they are psychologically ready for the delivery process, because remember with the IUFD, it's intrauterine fetal demise, so that baby has already gone, no longer living, that birth date is also going to be their technical death date.
Is that still there?
Yes. So that's a lot to put on a client's plate. So they have to be psychologically ready for that. All right, so with an induction of labor, there's medical reasons and then there's the, elective. And our clients like, listen, I'm done being pregnant. I'm ready for this baby to be in my arms. I'm over this. I need it here and I don't need it here anymore. How can I be induced? Well, we need to make sure the cervix is ready, right? And we do that through the Bishop score. So, with this, we're going to be checking dilation, which is how open the cervix is. And I passed out some cervix rings, the stackers, and if our client cervix is closed, it's not dilated at all. That's not a very good start. And if their effacement or how thinned out that cervix is less than 30%, so like that's the center blue cervix, so you can see it's pretty thick. And then the baby's head, the station, or how far that baby's engaged. Basically, if it's a -3, they're still pretty volatile, or the baby's not down into that pelvis just yet. We're not looking good as far as a positive ending for an induction, bless you. And then the cervix, is it a firm cervix when you touch it? Is it pliable? Is it not pliable? Can you open it? Can you move it? Or is it just hard? If it's hard, it doesn't make a difference how much medicine we give to our client. It's not going to open up because it's hard, right? Versus one that's very pliable, able to stretch, okay? Easily stretchable as that baby comes down on it. That would be good. And then if the cervix, where's the cervix positioned? Inside of mom. In early labor, often the baby's head is going to come down and it's going to push the cervix back. Okay, so that's called posterior. And instead of the cervix being basically up and down like this, it's back. Okay? If it's back like that, anytime a contraction happens, it's not going to be pushing down on the cervix. It's going to be pushing down on the lower uterine segment. Not going to dilate. So in that case scenario, all the red, this client would get 0. I would not schedule this client for an induction. If they were scheduled, I'd cancel it. Or if they were adamant about it, I'd be like, okay, but you're going to have to come in the night before and we can, ripen your cervix, get it softer, get some contractions going, This way you'll have the ability to have a positive outcome. So with everything, it stages up. So if there's somewhat open to 4-5 centimeters dilated, likelihood they're gonna have a good outcome with an induction or augmentation, it goes up. Yes, sir.
If they're preterm and they wanna do that, can we like educate them on the importance of having it in term?
If your client is preterm labor and they come in and they're like 35 weeks and they're like, I'm over this, I just want to,
37, 36, something like that.
yeah. Unless there's a medical reason, the physician's not gonna do it, and so then it would be a lot of education. Yeah.
If they're dilated more than 5, would there even be, that would be necessary for an induction?
At that point, we would probably call it an augmentation because their cervix is opening, they're probably having some contractions, but then again, it could be a situation of an incompetent cervix where the cervix isn't just strong enough to hold that, the weight of the pregnancy, and it's just naturally opening. So with those, a lot of times we go in, we break the water, the physician breaks the water, it's not the nursing role. And after that water is broken, the water wedge is gone, and then just go into labor. To schedule an induction for non-medical reasons, yes, 39. Because remember, a due date is plus or minus 2 weeks. So at 39 weeks, it could be, they really could be 37. But if we did it at 38 weeks, they could really be 36, which, those, yeah. So we want a Bishop score of about 8 or above. So ways of inducing or softening cervix, getting people up and going. They can do a Foley catheter, where we know Foley catheters, kind of the big no-no, right? But we're not doing it urinary. We're putting it up inside the cervix and blowing up that balloon. A balloon at the end of the Foley catheter is about 4 centimeters. So is that pressure? Yes. A little bit uncomfortable? Yes. But what it does, it's irritating that cervix enough, causing some contractions to happen, which will increase hormones, which will help to soften the cervix, which will help to put that client into labor. And when the catheter falls out, we know our client's about 4 centimeters. Okay? So, can do the old natural herbal remedies, drink our tea, right? Intercourse, acupuncture, and enema. And enema, that's the wrong area. But why? Pressure. We're going to clean up that colon, stimulate everything down there, because we know everything's pushed up and around that uterus. So if you got lots of fluid and stool moving around really fast, it'll irritate that uterus, right? Stripping amniotic membrane. Who's had their membrane stripped? That's fun. Everybody's looking at me like, no. Yeah. What they do is they go up inside the cervix, inside the uterus, bless you, and they literally strip the amniotic membrane. And I'm not flipping y'all off, it's just how it happens, okay? So they just strip it from the uterine wall, and it feels like they're trying to check your tonsils from the wrong end, okay? Because they're checking and they're stripping those membranes. And by doing that, remember that fetal fibronectin test? That's basically what they're doing. They're separating that, and that will start to irritate that uterine activity. And then they can also do an amniotomy, and that's what I'm looking for in here. That just sounds bad, doesn't it? You better push hard, right? With the amniotic membranes, there's lots of water that's inside the uterus, so we consider that like a water wedge. And with the water wedge, we want to get rid of that, because if you think of a water balloon, you can squeeze that water balloon, I almost fell, squeeze that water balloon, and it's gonna, not put the pressure in the right area. So if we take care, and this is not something a nurse does, the physician will do, we will assist the physician. But if they take care of that water wedge, they pop that balloon, they pop those membranes, all that water's gonna come out, so this way when the uterus contracts, it's actually gonna contract that baby down onto the cervix. So an amniotomy is one way. And this is how they do it. It's like a little beak, there's just like a little sharp tip at the end. All right, and then our good old oxytocin. We talked a little bit about softening or rightening the cervix. The catheters, the Foley catheters, they can also do side attack. Now this, did you have a question?
Yeah, but if you need to finish.
Oh, it's okay.
I was just wondering, so do we only use oxytocin if we're inducing labor? Like if a mom comes in and her membrane is already ruptured and she's like dilated to the floor, like do we have to put her on oxytocin still, or can we let her just do it naturally?
We can just let her do it naturally. It really
I just
depends
haven't
on,
seen a labor yet that a mom has to have oxytocin.
that's because we are, impatient souls. And, yeah. Yeah, but if a client comes in and they're like, I do not want oxytocin. Okay, yeah, yeah, because basically oxytocin is gonna force contraction, strength, frequency, duration, stronger contraction pain. Yeah, and some people are just like, let's let nature do it. Yes, yes, oxytocin is the generic, oxytocin, yeah, yes.
So for this cervical with the catheter, are they at the same risk of infection as you would with the urinary catheter?
No, because we still have the amniotic sac being a barrier to infection. With a urinary catheter, it goes straight up into the bladder. This isn't going up into the uterine cavity. Now, if water was broken and they were doing that, obviously, anytime you introduce anything at that point, they're gonna be at a high risk of infection, but they were already at a high risk of infection because their water was already broken. So, no, I'm gonna go with a no, not at the same risk. Yes. All right. And then the dilators that expand, those we use for our demise clients. They're seaweed, and they go up inside the cervix, and they absorb the fluid, and then they just open it up as that. It makes everything very tender, but they can't do that. Stripping of the membranes, AROM is an artificial rupture of membranes. There can be an SROM. If AROM is artificial, what would SROM be? Spontaneous, regular, yeah. It happened all by itself. Spontaneous rupture of membrane. Okay. So we're always, when you're thinking about Pitocin, oxytocin, we're always going to do it for an induction or augmentation via a pump. Okay, we're gonna titrate it very slowly. They can start at 0.5 milliunits or up to 2 milliunits, and then they can go up to 20 milliunits, but rarely will we really get to 20. Usually we stop about 10. That gets them into an effective pattern. But if we go too high, it's not gonna make a difference. We're gonna supersaturate those nerve endings, and it's not gonna work. It's actually gonna have the opposite effect. All right, we're always gonna keep our clients on the fetal monitor, the electronic fetal monitor, which is the EFM, because we're gonna be watching for decelerations. What kind of decelerations? There's 3 of them. Early, late, variable. Very good. Okay, because we want to make sure baby's doing good in there. So the client is always gonna be on the monitor. Now, they can be on a tethered monitor, which is connected directly to that machine, or they can be like, one where they can get up and walk around. Yeah, that word left me. They do it for cardiac. Yeah, but like where it's like, they aren't actually connected to it. Like, yeah, it was a big word, telemetry. Yeah, I'm like, it went away. But yeah, so they actually just put it, and it looks like a big old spider, and they can put it on there for the baby heart rate, and then the TOCA, which is the uterine contraction, and then they can just walk around, as long as their water's not broke. Which gives it more freedom, because where's the worst place for a person to labor? In bed. Yes, yes, flat on their back, in bed. Let's get our mamas up, get our clients up, walking around. Let's use gravity, right? Okay. Okay, but remember, just like with MAG, they can get too much. Pitocin, they can get too much. So we're going to be looking for too strong contractions, too long contractions. We'll be watching baby's heart rate. So if our contractions get too close, so the frequency is too close, what can we do? There you go. I was going to say, you guys are thinking too deep. Bring it back up, right? We're giving them too much medicine. What are we going to do with medicine? We're going to slow it down. We're going to cut it in half. We're going to do something. We're going to take the medicine away. Because we're forcing that client into labor. So if they're having too much contractions, we'll make it go away. Yes.
So oxytocin is also like the feel-good chemical, the love chemical or whatever.
Yes.
And so like, could a partner ever be just too supportive, right? and they have to like back off on the love and the support and
That's what he tells.
Yeah. It happens.
And so that's why a lot of men bring their like Switches and Game Boys and stuff.
I'm like, I don't even know if I should walk into that mud puddle.
Well, we just don't want to be too supportive, right? Like you were just talking about, you gotta back it off.
Okay, so, I'm gonna try to answer it.
We can go
I'm gonna answer it. So, when somebody is about to have their period, or they're having their period, and they are like, you're breathing too hard, buddy. I gotcha. You're breathing too hard. You're gonna have to go breathe in a different room, right? These clients have a ton of hormones going through them. So,
the love hormone.
but yeah, but love can easily be switched, right? Yeah, I mean, it can go from I love this person to death. Right, yeah. But don't worry, it goes back down after the baby's born, and then hopefully, yeah. That's the only answer you're getting out of me for that one. Okay, all right. So oxytocin, we're gonna be watching for too much contractions. Placental abruption, why would oxytocin cause placental abruption? Too much force, right? Uterine rupture. Same, if they've had a C-section before, if they've had any kind of uterine surgery, probably before y'all were born, or the majority of you were born, we had that huge ice storm here, and I had a client come in. It's when I was working at Doctors, when Doctors was, before it was a Catholic hospital, and it was her first time being pregnant, but she had a uterine rupture, which was really strange until she actually had enough perfusion in her brain that she's like, oh yeah, I had a uterine surgery where they removed a fibroid and they perforated my uterine wall. And we're like, oh yeah, that's why. But yeah, that baby was already on the outside of her uterus. Somebody in here had a uterine rupture? Yes. Go for it.
So I experienced a uterine rupture after I had twins. I had a C-section with twins, and I had a normal, healthy pregnancy. And it was like the day before my due date, and I felt a very sharp pain in my abdomen, and I immediately started having like the worst pain in the world. Like I'd never experienced contractions until that day, and they were extremely painful right off the bat. There was no building up. I went to the hospital. They didn't know what was wrong with me, and they suspected it could have been a rupture, but I had pain in all different locations, and it wasn't just one spot. And they're like, well, usually if it's a rupture, it'll be where your C-section was. It wasn't. It was all over. It wasn't until, like, I'll spare all the details, my heart rate, my baby's heart rate, like, dropped. And they're like, all right, well, let's just do a C-section. And that's when they discovered my uterus ruptured in 2 spots, where the C-section was, and then at the top of my uterus, my daughter's hand was hanging out inside my uterus, and I was bleeding out internally and everything. I ended up having to get blood transfusions, and it was a big mess. So.
That's scary.
And how many weeks did you say you were?
I was 39 in 6 days. But that was just the one baby. I had twins before, normal, healthy, twins.
Via C-section.
I did have a C-section.
Yeah. So that top part probably was stretched so much with your twins that it made like a window
Yeah.
for this one and all. Hey.
Yeah.
Yeah. Yeah, you're lucky to be here.
Is that why they say, like, some people say if you have a C-section, you'll always have to have a C-section because you're likely to have the rupture?
That was an old way of looking at it, and it, depending on the type of incision on the uterus, you will have to have a C-section for safety. If it's a low transverse and it's been a couple of years, that usually we can do a trial labor just to see, but we're gonna watch them pretty close. Yeah, but not anymore depending on the uterine incision.
I was thinking back on that. I heard that after you do one C-section, you can still do regular vaginal birth, and if you have 2 or more C-sections, so that you're gonna have to do C-section for the 4th.
Just remember, every time they cut through an area, it's gonna weaken the
Right.
Connective tissue.
That's why.
Yeah.
Yeah.
So we're dealing with safety at that point.
Right.
Yeah, yeah, thank you so much for sharing, because it's an awesome story, awesome story for educational reasons, not to ever experience it.
Was your daughter, was she normal?
My daughter is perfectly fine.
But like,
Exactly. She was a 9-pound baby. I was trying to do a VBAC, but I had to rupture before I even had a chance.
Your body said no.
Yeah.
But basically, because you already had a C-section before.
So when we are doing an induction or watching our clients labor, we're always watching for negative things that may happen, like a rupture or fetal distress. And just like with our typical adult body, we're gonna intervene, right? So if it's a deceleration, we're gonna change their position, right? We're gonna try to increase perfusion with the least invasive to the most invasive. And they probably, when they put you on a monitor, they probably flip-flopped you in the bed.
Actually, no.
Oh.
They did not even want to admit me to the hospital because I had no dilation. And they were gonna send me home, but I was puking and in excruciating pain. But they said, well, you're only dilated to 1, so we don't want to admit you. And they're like, you seem to be in a lot of pain for someone that's only dilated to 1. They made me get late on pain medicine, and we're waiting to see if I would dilate at all before they would even consider admitting me. They did say, oh, you're now a 2, so we'll admit you. And then I got pain meds about an hour later.
But you were bleeding that whole
I
time.
won't tell you what hospital it
Yeah.
was.
Nor would I ever ask. But, oh, I don't, what, I'm so glad you're still here. Yeah, and your daughter, I won't, yeah, and your daughter. Yeah, yeah, that's pretty crappy. So if our clients are being induced and we're seeing late decelerations or any kind of decelerations, we're gonna turn off our Pitocin, oxytocin, or decrease it. We're gonna try to dilute any kind of hormone that's causing the contraction, so we're gonna hydrate our client. We're gonna give them O2 if that pulse ox is less than 100. Why would we put a face mask on somebody who's already reading 100% O2? Whether, can you get better than 100? There's no extra credit in life.
Right.
Right? Do I need to divert my eyes while you take care of that? So, one of the reasons is that we're anticipating a drop because they may be starting to bleed out. So we're gonna make sure that we're gonna support them. A1 standards, that's our regulatory guideline producing, hey, this is what you're gonna do, people. They say, don't put it on until they're 100%, but you'll see in the hospital that it actually does happen. And then we're always gonna notify the physician, the PCP, primary care provider, because something's happening, okay? All right. Best practice states to not do O2 until they drop below 100. Being nurses and forward thinkers, we know they're gonna drop. Yeah. So like on a test question, we would take that big, huge variable out of it and be like, you know, patient stats are 90. Yeah, we're throwing O2 at them. You know, we're not gonna be like 99, 100. No, that's not fair. But yeah. All right, so things that we could be doing to help our clients if they're having variables, having deceleration, showing some kind of distress, we could do an amnio infusion. So that's when we're actually pushing fluid back up into the baby, back into the uterus with what we call an IUPC, which is an intrauterine pressure catheter, and this goes up inside the uterus. It's not something we place because of high risk of placental perforation, but we would attach an IV line here, warm normal saline, and then we would just be putting fluid back up into that uterine cavity. We could do this if they have super thick meconium, if they have huge ugly variables, something that's like cord compression, severe oligohydramnios, something like that. Okay? Let's see. What other kind of things? Oh, emergencies. This is where it goes. Okay, so cord prolapse. What would cause a cord prolapse? A low-lying placenta, maybe. What else?
Oligo.
The hydramnios. Yeah, polyhydramnios, because the baby inside the uterus has too much fluid, and if that fluid broke and then all that water came out, the cord will follow it. Yeah. Membranes aren't intact. Oh, okay. So an occult, if that baby is not the question is, how could you have a cord prolapse if the membranes weren't intact, or were still intact? If the baby's not engaged, you can have fluid below the baby's head, and that can slip to be on this side of the baby's head. So this way, it's in front of the presenting part. We'll see cord prolapses with breech babies because they don't fit nice and tight into the pelvis. So you can have that fluid that starts coming out, bloop, and then the cord follows it out. What would we do? Would we take it and just jam it right back up in there?
Place it.
Yes, sir.
I'm going down the rabbit hole again. So, baby breathes through the umbilical cord, correct? Like gets oxygen and stuff through the umbilical cord.
Baby's whole perfusion and everything is through the umbilical cord.
Right. So, I had somebody that they said that the baby passed because it wrapped around
A nuchal cord.
the umbilical cord wrapped around its head.
That is a little bit different than a prolapse. Prolapse cord,
I mean,
We go
while
like-
the baby was still inside.
yeah.
So,
The prolapse cord is like this. A nuchal cord
and they
is
just,
like that.
would that lead to fetal demise also?
They can, depends on how tight it is, because,
Baby's still trying to like.
yeah,
Okay.
because it's strangling them.
Yes.
And you need the brain to be perfused. If brain's not being perfused,
I mean, if it's
That
if
and
they're
then-
perfusing through the umbilical cord.
But it's cutting off.
what would happen if I came to you and
right,
like
right, okay. Sorry, I'm dumb.
both sides of
You're
the,
not done.
you got it? It's okay. It was, you said it was a rabbit hole, right?
Yes.
So, yeah. So that's called a nuchal cord, and that's when the cord is actually wrapped around the baby's neck, like that. And that can be, you can deliver babies with nuchal cords. I've delivered several babies with nuchal cords, and basically what we do is we just reduce it, because we'll feel for that cord here, and then we'll take the cord and try and flip it over the baby's head. If it's non-reducible, we will clamp it and cut it at that point, and just unwrap it. Okay. All right, so interventions for a prolapse cord, we're gonna, there you go, we're gonna get that, whatever is pushing on that cord, we're gonna relieve that pressure, right? We're gonna call for help. Just think CPR, what do? We see that person down on the ground, we're like, hey, Annie, are you okay? Do they still call her Annie? I still call her Annie. Are you okay? And then, of course, there's no response, and you're like, what?
Call
Yeah,
911.
you, call for help, right? You, go get an AED. And then you start doing it, right? Start doing your stuff. Well, same thing with this. We're calling for help, we're restoring perfusion. How we're restoring perfusion? We can turn them on their side, we can put them in a knee chest. If that's still not doing it, we're gonna do an exam, and we're gonna take our hand, and we're gonna push whatever the presenting part is up off that cord. And then we're going to prepare them for a C-section. Yes, you get to ride back to the section room with that, with your hand there. They can be knee chest, they can be on their side, and you're just, most of the time you're up on the bed, and then after we move them to the table, then you're draped. So you're like, yeah,
Oh, you're right there.
yeah. Because you are the only person who's keeping that presenting part up off that umbilical cord, making sure that baby's perfused. Okay? So you feel everything, you feel them touching, and you're like, hey, that's my fingers. And they're like, no. I won't bite your to do when you're doing an OR case, you're always supposed to see where your hands are, right? And you don't. You can't in this situation because you're under the drapes. It's not gonna take that long. Alright, so here's our rupture. After you said about your daughter's hand, I was like, that's my picture. It's not really a picture of your uterus, it's just something I stole off of the
Looks similar.
So, but yeah. So we have a real life example of a ruptured uterus out. So one of my sweet dear friends, this was her third delivery. She had a C-section before. It was like 7 years prior that her C-section was. But she came in, we were inducing her, and she ruptured. She ruptured the crap out of herself. And then instead of the, her signs were very overt as soon as it did. And one of the things that we looked for, which I'm surprised that it didn't happen with you, or they just missed it, is that it will look like your client has a very distended bladder. It will have a great big bump, because it will usually happen with the transverse incision. And so as that's ripping, the blood and the fluid and everything is building up right there. So it'll look like a great big huge distended bladder. Now, with yours, since it did rupture 2 places, that might not have been as overt because it was bleeding out more. But, whew, talking like goosebumps everywhere. I'll have to get my hands on that chart, but no. So, but with that, you're gonna look for that. Now, her signs of the fetal heart rate drop and her vital signs, why was that not overt right away? Why did her heart rate and her blood pressure not show signs and symptoms of shock? Why did the baby's heart rate not totally plummet right away? What happens to the cardiovascular system in pregnancy? It expands, yes. So it takes a lot more volume to decrease before those signs are gonna actually show. And that may be part of the reason that they were missing it, but yeah, that was awesome, that's awesome. All right, so causes, too strong contractions, previous surgeries, we kind of hit all of this before. Prolonged labor, why would that cause a uterine rupture? Because it's too long, y'all are tired, it's tired, yeah, it's just gonna rip. Most of the time, what we're gonna see the rupture is from too close deliveries, pregnancies, weakened connective tissue, an overdistended uterus, something that's put a lot of tension on that scar, so that tensile strength isn't there. It's just ready to go. Okay. Look how many things I can carry around with me today. All right. So see, this is that overdistended bladder look. Okay. So it really looks like a Bandel's ring, because it looks like there's a ring around, or a band around the client's belly. So how many have seen just in adult nursing an overdistended bladder?
Oh.
Okay, so a few, this is what it looks like. All right, so if you kind of keep that in the back of your head, it makes that, and then combine it with change in vital signs, change in heart rate for the baby, pain, there is dramatic amount of pain. So, yeah. If it's in my friend's case, she was able to deliver vaginally. They did do forceps on them. That's mechanically assisted birth and MAB. And there's so many choices in here. All right. So they went in, they slide one in on one side and one in on the other, bring it together, and then assist that baby out. They can do forceps, they can do a vacuum. Okay, the vacuum works the same way. They would put it on the baby's head and then pump it up until it gets to the green area, and then they would pull the baby out with that.
I had to do that
So,
with me,
with-
and it gave me
With
like
both, we're always
coma.
gonna watch
And my dad cried whenever I was born.
our
He was
baby's
like,
heart
oh my
rate.
gosh, she's gonna be made fun of
Make
for
sure
the
they
rest of
don't
her
get
life.
into too bad of distress, like we know.
Yeah.
We know this is gonna cause a lot of distress on our babies and moms. So, but my day of nursing, because I always think I'm an old nurse, started nursing in 1990, that is, okay? Yeah, old. Florence Nightingale and I knew each other well. So, we always use forceps, and when I say we, I mean the physician, and we would help them. And then they went to more the common practice now is the, we call those vacuums, the Mighty Vacs or the Kiwis. They all are different.
What about the baby soft spot?
Is there?
I seen one.
Did you?
It's like a little soft spot, like,
They put it like wherever they see the head, they're putting it, they put it like right here on my finger.
So the, oh my gosh. I was like, somebody take a picture, I don't have my phone on me.
What happened? She put it on
Put it
her
on forehead.
Oh.
I usually look for somebody that doesn't have a lot of hair, but we have fully headed hair people this semester. So, but to demonstrate. Now with those, obviously something has to be happening dramatically to do, to do something that dramatic on them, right? So these are preemies. Okay. But if our mom is like super tired, that baby's gotta come out, right? We can't be like, take a 4-hour nap, we'll come back and do this. No. We're gonna get that baby out for them. They're like, just give us 2 more pushes, just 2 more, you got this, can you do 2 more pushes? No. So, but yeah, we really just, that's a whole lot of coaching and support and all that, yes. There are a certain amount of pop-offs. We don't like, we're gonna count every single one of them. After they get beyond 2, we're gonna be like, you've had your 2 pop-offs. Those are 2 pop-offs. And what we're doing, talking pop-offs, I'll get to you. And this is just a different one. This is if that baby's asynclitic, we're gonna move it and make sure that it comes out straight at that point. But a pop-off is, we put it on there and it makes that exact same sound. So we did that pressure, pull, and it came off that baby's head. And why would we need to know how many pop-offs there were? We're gonna be causing some broken blood vessels, right? If there was 3, 4, 5, we're gonna be doing some bruising. And then maybe after the 5th one, and the nurse is like, listen, dude, stop, just stop, right? That baby's not coming out this way. But we might have caused so much stress pulling that head and head and head that they're gonna have, some neurological damage.
Just for preemies?
I can see.
That's for anybody.
For general?
Yeah, these were just preemies.
Oh, that's.
Yeah.
Those are preemies, yeah.
Is there like a chance that it'll like
That's fun.
break?
Oh, yeah.
Break?
Yeah, break the skin.
Okay.
Yeah. So, just real quick touch on amniotic fluid embolus. This is when some of the amniotic fluid gets into the vascular system for the client and it causes a total system shutdown, yes.
I would say we've talked about all these alternatives and everything, but the only place I've seen that episiotomy mentioned is that in that little HELP acronym, or helper. And so why is that not best practice anymore, or is that out of our scope to even consider, or what, why isn't that
Both.
in the conversation more?
Both. It is not considered best practice. Yeah. With an episiotomy, the reason that we would do a surgical incision, and it's not a nursing role.
Sure.
The episiotomy would create more room on the perineum for that baby to be delivered. So if we were doing a forceps or a MAB, we're adding girth to that baby's head, and mom's perineum might not be able to stretch as far, so they want to create more.
Why isn't there a slide, right? We talked about the forceps, we've got routine around the sutures and the top.
Because it's really not best practice. Usually we're gonna let them tear. Yeah. And it's gonna be supported. We're gonna support the perineum during any delivery. So this way they don't tear into their rectum. But really an episiotomy is not best practice anymore. Now, do they still happen? Yes, of course, but. All right, so with amniotic fluid embolus, that's like causes full system shutdown. It's very rare, but you should know that it can happen. Let's see, there's lots of things. Okay, so here's your mechanically assisted birth. Kind of shows how they happen. All right, so somebody asked, does it cause some tearing of the skin? And yes. So this has happened with a vacuum, and then also the circle on the cheek is from the forceps. C-section, indications for a C-section, CPD, yes.
I have a question on the mechanical. So it's.
Oh, careful.
Say like they had this little, like when they had some mechanical. Does the patient sue us for that, or we under some like sort of contract where like, that was necessary, we're sorry that happened?
Patients can sue you for anything. It's like 18 years that you're still liable to them after the delivery.
Well, I was to say, you can sue anyone for any reason, but it doesn't mean they're gonna win.
Yes.
Oh, this side
You're
doesn't
actually
have
gonna be held liable and they can file a lawsuit over anyone.
You just have to show reasonable, say, this is what you did reasonably. These are the actions your competent nurse would perform in this situation. For forceps, no, but that can be included in needed operations, yeah.
Can you refuse this, like if the doctor's like, no, please leave that to
It's your body, you can refuse anything. Yes. You can say, that was a good pop-up. That's one. We can do some maneuvers to try and get that baby maybe a little bit more in line with the delivery, pelvis, vaginal vault, something, because it may just be out of alignment at that point. I mean, if you look up, it's called spinning babies, and that is really something that is nurse driven, and it's very physician. That's the whole format of it, and it's really cool. They do it at Baptist. They do it. It's considered almost best practice now. A1 supports it and all that.
Fridays usually.
That's where they use the peanut ball, and you'll see that with Mrs. Gottney.
But I will say
We have some back in our skills lab and all that.
and Sunday. I'm gonna watch Avatar the last day.
Would it be good to get consent? Yeah, but really that client is under duress and that consent is null.
That's not saying. That's not saying.
run all the plans for your client. And that's where that birth plan is awesome, because all those things are upfront. Hey, I don't want this. Hey, I don't want this. Hey, I'm good as long as my baby comes out of my body
You
and
wanna come
goes
and watch it
alive.
later?
You know.
You wanna come and watch it later? Or
All right, so you guys have been through peri-op?
that is today.
Awesome. Same thing happens for the C-section. All right, so we talked a little bit about incisions, and I was talking about the lower uterine transverse. Those are called Fannin steel, and those are way down low. And the reason that we would want to do an incision on the lower part of the uterus is because that's the thinnest area on the uterus versus up and down. And then also, if you think of the fibers, the muscle fibers on a uterus go like this. They go up and down, so if it's cut like that, it's gonna heal better versus a vertical incision where it's not gonna have a strong scar. Now, with our VBAC, there's general, regional, you guys got that popped down awesome. All right. So a VBAC, vaginal birth after cesarean, there are some criteria for the VBAC, and those go, you know, what type of incision was on the uterus, because you might have a vertical incision on the skin, or you might have a low transverse on the skin, but then on the uterus, it's a vertical. Okay? So whenever you're looking at the records, you're looking for the uterine incision, or classical incision on the uterus, and those we can't do. Now, why did that person have to have a C-section before? Was it for CPD? And then it was like a little 6-pound baby. And the next pregnancy, they're, you know, scaling out to be, you know, 8, 9 pounds.